Welcome to PSY 318, Study Session 5, Disruptive Behavior Disorders. Introduction. Children often break rules or misbehave. If they consistently display extreme hostility and defiance, however, they may qualify for a diagnosis of oppositional defiant disorder or conduct disorder. Disruptive behavioral disorders are characterized by deficits in self-control and involve behavior tendencies like hyperactivity, inattention, aggressiveness, destructiveness, and defiance of authority. The symptoms tend to emerge in the preschool and elementary school years. There are three types of disruptive behavioral disorders, namely conduct disorders, oppositional defiant disorder, and attention deficit or hyperactivity disorder. Objectives. At the end of this lecture, you should be able to 1. Identify oppositional defiant disorders, 2. Identify conduct disorders, and 3. Identify attention deficit or hyperactivity disorders. Pretest. 1. What are the characteristics of disruptive behavioral disorders? 2. Name the three types of disruptive behavioral disorders. 3. Mention the diagnostic criteria for children with conduct disorder. 4. Mention the three subtypes of attention deficit or hyperactivity disorder. 5. Mention the distinction between oppositional defiant disorder and conduct disorder. Content. Oppositional defiant disorder. Children with oppositional defiant disorder argue repeatedly with adults, lose their temper, and feel great anger and resentment. They often ignore adult rules and requests, try to annoy other people, and blame others for their own mistakes and problems. Between 2 and 16% of children display this pattern, APA 2000. The disorder is more common in boys than in girls before puberty. Built equal in both sexes after puberty. Probably because many boys with this disorder actually worsen during adolescence and develop a more extensive and severe antisocial pattern called conduct disorder. Children who meet diagnostic criteria for oppositional defiant disorder, ODD. Children who meet diagnostic criteria for oppositional defiant disorder, ODD, are negativistic, hostile, temperamental, and defiant towards authority figures over at least 6 months. Although the non-compliant behaviors of children with ODD are usually manifested toward adults, these children are also prone to be negativistic towards peers. Many steal from, threaten, or harm their victims, committing such crimes as shoplifting, forgery, breaking into buildings or cars, assault, and armed robbery. As they get older, their acts of physical violence, many include rape or, in rare cases, homicide, APA 2000, 1994. Conduct disorders usually begins between 7 and 15 years of age, APA 2000. Children with mild conduct disorder may improve over time, but severe cases frequently continue into adulthood and may develop into antisocial personality disorder or other psychological problems, FAIR 2000. The distinction between ODD and conduct disorder is based on the presence of violating of law or basic social mores. Children with ODD do not engage in repeated physical aggression, property destruction, theft, or deceit. Both disorders tend to occur in sequence and are associated with problems in understanding and solving interpersonal problems. Both disorders are also associated with increased risk for antisocial behavior in adulthood. Conduct disorders are characterized by persistent behaviors that seriously violate the rights of others and basic societal norms. Children with conduct disorder often get in trouble with the law, and some become career criminals. Children who meet diagnostic criteria for conduct disorder repeatedly violate very basic norms for interpersonal behavior. They are often physically aggressive and cruel to others. They may habitually lie and cheat. Societal factors might play a role in most serious cases of conduct disorder. There is also a biological basis of vulnerability to conduct disorder, a constitutional vulnerability to conduct disorder. Heredity is one source. Genetic factors play a role in determining which children have conduct problems and which do not. Cases of conduct disorder have been linked to genetic and biological factors, drug abuse, poverty, traumatic events, and exposure to violent peers or community violence. Treatment for conduct disorder are generally most effective with children younger than 13. Given the importance of family factor in this disorder, therapists often use family interventions. Sociocultural approaches such as residential treatment in the community, program at school, and group therapy have also helped some children improve. Fairs, 2003. Individual approaches are sometimes effective as well. Drug therapy has also been tried to help control aggressive outbursts in children. Institutionalization in juvenile training centers has not met with much success. Attention Deficit Hyperactivity Disorder, ADHD. This is the most frequently diagnosed disruptive disorder of childhood. DSM-4 distinguishes three subtypes of this disorder: attention deficit hyperactivity disorder, combined type, attention deficit hyperactivity disorder, predominantly inattentive type, and attention deficit hyperactivity disorder, predominantly hyperactive. These distinctions are made because children may show only one aspect of the syndrome: attention problems or excessive activity level. In majority of cases, however, they show problems with both attention and activity level. In order to be diagnosed with ADHD, a child must show developmentally inappropriate attention problems, impulsiveness, and motor hyperactivity. In the classroom, the attention difficulties are often manifested in an ability to stick with a specific task. Children with ADHD have difficulty organizing and completing work. They often give the impression that they are not listening or that they have not heard what they have been told. Just sitting still seems to be a major challenge for them. When they interact with peers, children with ADHD are sometimes awkward and disorganized. Similarly, at home, they are described as failing to follow through on parental requests and failing to sustain activities, including play for periods of time that are appropriate for their age. A good example of a child with attention deficit hyperactivity disorder is provided in the following case. Victor was 4 years old when he was first admitted to a children's psychiatric ward as a day patient. As soon as he could crawl, he got into everything. He had no ideas of danger. He slept very little at night and was difficult to pacify when upset. It was only because he was their only child and they could devote all of their time to him that his parents managed to maintain him at home. His problems were noticed by others just as soon as Victor began preschool at age 3. He made no friends among the other children. Every interaction ended in trouble. He rushed around all day and could not even sit still at story time. His flitting from one activity to another completely exhausted our teachers. After some 18 months of trying, his teacher suggested that he will be referred to hospital for assessment and treatment. On examination, no gross physical damage can be found in his central nervous system. Psychological examinations revealed that Victor had of nearly average intelligence. In the hospital, he was just as hyperactive as he had been in school and at home. He climbed dangerously to the top of the outdoor swings. He ran from one plaything to another and showed no consideration for other children who were using them. Left to his own devices, he was constantly on the move, tearing up paper, messing with toys, all in a non-constructive manner. Victor was placed in a highly structured classroom with 2 teachers and 5 other children. There, his behavior was gradually brought under control. He was given small tasks that were well within his ability, and he was carefully shown how to perform them. His success were met with lavish praises. Moreover, patience and reward gradually increased the length of time he would spend seated at the table. Victor had an especially severe form of ADHD. He was hyperactive, always on the go, with apparently boundless energy. He was impulsive, doing whatever came to mind, often without regard to physical danger, and he had problems focusing his attention on any one task without a great deal of support from teachers. Eventually, Victor was placed in a small structured residential school. By age 16, he had settled down a great deal. He was no longer physically overactive, but his conversations still flitted from one subject to another. He had no friends among his peers, although he could relate reasonably well to adults. Victor showed little initiative in matters concerning his own life, and his prospect for gaining employment was not good. Children who display ADHD have great difficulty attending to tasks or behave overactively and impulsively, or both. The disorder often appears before the child starts school. The symptoms of ADHD often feed into one another. Children who have trouble focusing attention may keep turning from task to task until they end up trying to run in several directions at once. About half of the children with ADHD also have learning or communication problems. Many perform poorly in school. A number have difficulty interacting with other children, and about 80% misbehave. Often quite seriously, it is also common for children to have mood or anxiety problems. The disorder usually persists throughout childhood, APA 2000, 1994. Many children show a marked lessening of symptoms as they move into mild adolescence, but at least half continue to have problems. Fairs 2003. ADHD have been considered to have several interacting causes, including biological causes, high levels of stress, and family dysfunction. Barkley 2002. DSM-4 cites prevalence rates in pre-adolescence ranging from 3 to 5%. The proportion of children who meet the diagnostic criteria for ADHD varies as a function of 1. How information about the child's behavior is obtained from parents, teachers, or clinical observers. 2. The nature of the setting, classroom, playground, or home. And 3. The child's family background. Teachers are often the first to recognize ADHD in a child. This is especially true of children from lower income families. Many children grow out of the symptoms of ADHD as they get older. Genetic favors are involved in some of the cases of ADHD. Vulnerability to ADHD is also increased by environmental factors that interfere with brain function. The child's social environment may also be a factor in symptoms of ADHD. Treatment. The two main treatment approaches to ADHD are medication and behavioral therapy. 1. Either of the following groups. A. At least 6 of the following symptoms of inattention persisting for at least 6 months to a degree that is maladaptive and inconsistent with developmental level. A. Frequent failure to give attention to details or making careless mistakes. B. Frequent difficulty in sustaining attention. C. Frequent failure to listen when spoken to directly. D. Frequent failure to follow through on instructions and failure to finish work. E. Difficulty in organizing tasks and activities. F. Avoidance of dislike and reluctance to engage in tasks that require sustained mental effort. G. Frequent loss of items necessary for tasks or activities. H. Easy distraction by irrelevant stimuli. I. Forgetfulness in daily activities. B. At least 6 of the following symptoms of hyperactivity, impulsivity, persisting for at least 6 months to a degree that is maladaptive and inconsistent with developmental level. A. Fidgeting with hands or feet, or squirming in seat. B. Frequent wandering from seat in classroom or similar situation. C. Frequent running about or climbing excessively in situations in which it is appropriate. D. Frequent difficulty in playing or engaging in leisure activities quickly. E. frequently on the go activity or acting as if driven by a motor. F. Frequent excessive talking. G. Frequent blotting out of answers before questions has been completed. H. Frequent difficulty in awaiting his turn. I. Frequent interrupting of or intruding on others. 1. The presence of some symptoms before the age of 7. 2. Impairment from the symptoms in at least 2 settings. 3. Significant impairment. Summary. Children with oppositional deference disorder argue repeatedly with adults, lose their temper, and feel great anger and resentment. Between 2 and 16% of children display this pattern, APA 2000. The distinction between ODD and conduct disorder is based on the presence of violations of the law or basic social mores. Children with conduct disorder often get in trouble with the law, and some become career criminals. Conduct disorders usually begin with 7 and 15 years of age, APA 2000. The 3 subtypes of attention deficit hyperactive disorder are 1. Attention deficit hyperactive disorder, combined type. 2. Attention deficit hyperactivity disorder, predominantly inattentive type. And attention deficit hyperactivity disorder, predominantly hyperactive impulsive type. When they interact with peers, children with ADHD are sometimes awkward and disorganized. ADHD is the most frequent diagnosed disruptive disorder of children, DSM-4. In order to be diagnosed with ADHD, a child must show development, mentally inappropriate attention problems. At home, child with ADHD are prescribed as failing to follow through on parental request. Post-test. 1. Disruptive behavior disorders involve behavioral tendencies like dash, 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 and dash. 2. Dash, dash, and dash are the types of disruptive behavior disorders. 3. Between dash and 16% of children display ODD pattern. 4. Children with dash engage in repeated physical aggression. 5. Conduct disorder begins from between 7 and dash of years age. 6. Conduct disorders are characterized by persistent behaviors that dash. 7. Children with dash conduct disorder improve over time. 8. Dash is the most frequently diagnosed disruptive disorder of childhood. 9. In order to be diagnosed with ADHD, a child must show dash. 10. The causes of ADHD are dash and dash. End of study session 5. Thank you for listening.